at the time that we did this evidence review, the literature predated any of the COVID research. So although COVID has likely had an impact on the levels of fatigue in the healthcare and the aged care sectors, we didn't address that in this particular review. So I'll start with a brief background and methods and then move on to some findings on the prevalence and the outcomes for workers and impacts on patients. And then I'll talk about risk and protective factors, interventions, and finish off with some overall implications. So we know that the problem is that fatigue in healthcare and social assistance workers impacts on both workers and on the patients in their care. And this diagram illustrates the relationships between the potential risks and the different influences on fatigue and the consequences of fatigue. So in the middle there, we have physical, mental, emotional fatigue that are both an outcome of work-related risk factors and a determinant of outcomes for workers and patients. And then the individual risk factors like anxiety and depression and substance use also contribute to the development of fatigue and can exacerbate the effects of fatigue. And then at the bottom, we have some strategies. So the preventive strategies can be implemented at the workplace level to reduce the stressors that contribute to fatigue. And then interventions can also be implemented to help individuals build resistance or to develop strategies to cope with fatigue. And these are the specific research questions that we used. So firstly, what is the prevalence of fatigue, or the physical, emotional and mental fatigue on Australian healthcare and social assistance industry? Then also we're looking at the outcomes of fatigue on the workers, the impact of workers' fatigue on the patient safety, and what treatments and preventive actions can be implemented to address the risk of fatigue in that industry. Now, this flowchart shows how we identified the relevant literature, and these was literature published between 2010 and June 2020. And so from about 1,400 initial records, we found 49 systematic reviews after screening. And the Australian prevalence data, however, were not actually specified in those because they were international reviews. So we did a supplementary targeted search for Australian prevalence data and found an additional 14 studies. We also did a quality assessment using a checklist that was developed by McMaster University, and we found that the systematic reviews were generally moderate to strong in quality. However, there are some limitations in the studies that were included in those reviews. There were very few studies on aged care, community care, or the disability sector. There was also a lot of heterogeneity between the studies that were included in the reviews, and they were mostly lower levels of evidence. So for prevalence, it was all cross-sectional surveys, and for interventions, often uncontrolled before and after studies. And most of them rarely accounted for any potential confounders. So there was quite a high risk of bias. Now, before I move on to the findings, I'll just briefly talk about the definitions. So we started with definitions for physical, mental and emotional work fatigue that were described by Frone and Tidwell. But the data on fatigue were not really differentiated in this way in the literature. Physical fatigue, which is a relatively broad kind of concept, and it's often described as sleepiness or tiredness. So there were no gold standard measures. It was mostly self-reported. And although there are objective physiological measures, they were rarely used in the studies. Mental and emotional fatigue are symptoms that are often characterised in a number of different syndromes, including burnout and compassion fatigue and secondary traumatic stress. And these terms share conceptual similarities with a lot of common characteristics and overlapping definitions. And several instruments have also been developed to measure burnout. Maslach's burnout inventory was the gold standard for burnout, and that comprises three main dimensions. There's emotional exhaustion, depersonalisation, and personal achievement. But there was also quite a lot of variability in the way this instrument was used and interpreted. So basically, all of that is to say that I'm going to present the findings on emotional and mental fatigue, mostly in terms of burnout. So now we're going to have a look at the Australian prevalence for fatigue and burnout. The data on physical fatigue per se was not really provided in the literature. Instead, physical fatigue was discussed in terms of very long work hours or long shifts or night shifts and inadequate rest between shifts. So it's really used more as a proxy for fatigue. The identified reviews on prevalence were limited to the health and medical sector, and none of them identified fatigue in the aged care or support care sector. Now, based on data from the Australian Medical Association, a 2017 report, over half of doctors worked long hours that put them at significant risk of fatigue, and 10% of doctors worked an average of 78 hours a week. Amongst nurses and midwives, those that worked night shifts were more likely to report physical fatigue, and about 1/3 reported working 40 to 49 hours a week, and 8% worked more than 50 hours a week. And the Australian prevalence data was similar to international data, particularly in terms of the long work hours in doctors and nurses. The research also identified disciplines that were most at risk of fatigue, and 75% of intensivists, 73% of surgeons, 58% of obstetricians and gynecologists, and 54% of physicians were all at risk of fatigue. The international prevalence data on the systematic reviews was also similar to Australian prevalence studies for burnout. And as I mentioned before, mental and emotional report was fatigue was reported as compassion fatigue and burnout. And the cutoff scores for the Maslach's burnout inventory were designated either low risk, medium risk, or high risk of burnout. Another measure was the Copenhagen burnout inventory, which also measured burnout, but it measured it in terms of their personal, work-related and client-related burnout. So amongst nurses of all specialties, work-related burnout ranged from 43 to 51%, and personal burnout, they experienced 47 to 65% of those experienced that. Overall, the Australian nurses and midwives across all specialties were at what they considered a medium risk of burnout, according to the Maslach's burnout inventory, and up to 20% reported being at high risk of burnout. So they're not overall not in crisis, but it's certainly not ideal. For emergency department nurses, 77% reported a medium risk of burnout, and none of them reported a high risk. And across the physicians and specialists, up to 1/3 reported high emotional exhaustion, which is one of those dimensions of burnout, high depersonalisation, so up to 10% of those, and low personal achievement. So now we're going to have a look at the outcomes for of fatigue for workers. So this slide shows a summary of a range of outcomes that have been associated with fatigue. For healthcare workers, physical fatigue was linked to increases in musculoskeletal disorders, as well as increases in absenteeism, presenteeism, staff turnover or intention to leave, and a higher risk of burnout and stress. It was also linked to poor physical health, compromised mental functioning in terms of difficulty concentrating and making decisions, poorer clinical performance in terms of safety and accuracy, and it impacted on personal well-being with job satisfaction and dissatisfaction and poor work-life balance. And across the healthcare occupations, the main outcomes associated with mental and emotional fatigue or burnout were psychological and behavioural. And these included intrusive thoughts and irritability, poor mental health, also job dissatisfaction and career choice regret. So now we're going to have a look at the impact of healthcare workers' fatigue on patients. So overall, there were very little actual data were provided in the reviews, and it was mostly discussed in terms of potential or expected outcomes. So for nurses and emergency medical workers, there was relatively strong evidence that physical fatigue was associated with poor patient outcomes, specifically long work hours, that is more than 40 hours a week, and insufficient recovery time between shifts, so that's less than 10 hours rest between shifts, was associated with medication errors and near misses. But for surgeons, the evidence of an association between physical fatigue and patient outcomes, which were measured in terms of mortality and post-operative complications or medical errors, that was inconclusive. And that's really because there was insufficient evidence or there were mixed results. And any number of things could explain those differences. Nurses often have more contact with patients, so potentially have more chance of errors. Nurses also record better, and medical errors may actually be underreported in the medical records. So, for example, errors could be identified or corrected by others in the medical team before any harm is done, and so they might not necessarily be recorded in that way. In the literature, it is widely suggested that burnout in healthcare workers leads to poor patient outcomes, but there were very few empirical studies that actually assessed this. The most interesting finding was that physicians perceived that burnout had a negative impact on the quality of care they provided, and that they felt that it led to increased medical errors. But in studies that actually compared doctors' perceptions with noted errors or near misses in the medical record, there was really no significant relationship between burnout and patient safety or quality of care. And then there were some studies that looked at the patient's ratings of care, and these showed mixed results. So there was some limited evidence that showed an association between physicians' reported feeling emotional exhaustion and low personal sense of personal achievement, and patients who experienced their experience of poor communication with physicians. But overall, there was really insufficient evidence to suggest that physician burnout leads to poorer patient outcomes or compromised patient safety. Now, we also identified some risk and protective factors from the literature, and these could be potential targets for intervention or prevention strategies. So this slide shows a summary of the work-related risk factors that were most commonly identified. And these were things like workload, long hours, shift work, and inadequate rest between shifts. And these were risk factors for physical fatigue and burnout across all healthcare professionals. Lack of autonomy or control over the work environment was also identified as a risk factor for burnout across all areas of healthcare. And in some departments, like the emergency department and in mental health nursing, exposure to violence or threats of aggression or critical incidents were also risk factors for burnout. Bureaucratic job demands and risk of litigation and changing work environment were identified as risk factors for burnout in specialists and clinicians. And then there were some task-specific factors, such as poor ergonomic design of equipment. That was a risk factor for physical fatigue in surgeons. And this is a summary of the work-related protective factors that were generally the opposite of risk factors, like restricting hours of work and having adequate staffing levels, etc. But there were some additional factors that were identified, including job stability, reasonable workloads, ergonomic training and provision of support for workers, such as clinical supervision and mentoring, and also allocating tasks that were appropriate to an individual's level of expertise. Individual risk and protective factors were also discussed in the literature, but many of those are not really amenable to change. Generally, there was no significant association between fatigue and any demographic factors like age or gender or relationship status. Years of experience and level of education showed some mixed results, and it's possible that this was due to some confounding factors that were not really accounted for. So things like the frequency of contact with patients, and this could differ significantly depending on whether you're a nurse on the ward or whether you're a nurse manager. Mental health, anxiety and depression and substance use were often associated with fatigue, but these have been associated as both a cause and a consequence of fatigue. And then there's some additional individual protective factors that were discussed in the reviews, and these included things like high levels of self-efficacy and resilience, having a good sense of humour and optimism, engaging in hobbies outside of work, having a good social support network, and valuing the work that you do and feeling as if you make a difference through your work. Okay, so now we're going to have a look at some of the interventions and the preventive strategies that were implemented and evaluated. And there were two main types of approaches: preventive or proactive strategies that are implemented at an organisational level to reduce the stressors. These are things that change the work conditions, the culture, or the environment, and include things like modifying policies, reducing workload, having flexibility in the schedules, etc. The other approach is interventions that are directed at an individual to help them cope with stresses in the workplace. Things like resilience skills training and providing support for workers through supervision and mentoring, and access to relaxation programs like meditation or exercise. And this slide shows a summary of the effective interventions. On the top line are the organisational interventions. So sleep health education and fatigue awareness training had significant positive effects on the quality of workers' sleep, and it reduced the levels of burnout in the short term. Scheduled napping significantly reduced the level of sleepiness, and interventions that involved modifying job tasks or work schedules to reduce the overall workload also significantly reduced burnout in doctors. On the bottom line are individual-focused interventions, and these consistently reduced burnout and compassion fatigue. Things like mindfulness, meditation, and resilience training were beneficial in the short term. So ongoing sessions might be needed to sustain those benefits over a longer term. But overall, the interventions with an organisational focus were significantly more effective than those with an individual focus. But there was quite a lot of variability across the studies in the type of intervention, the format, the follow-up period, and the measures of effectiveness. So overall, the evidence from the literature suggested that combining organisational strategies to prevent fatigue with individual focused strategies to help people cope with fatigue in the workplace might be the best approach. And there was one review that recommended implementing a comprehensive strategy that used 6 key elements. These included education and training on fatigue and sleep hygiene, encouraging organisations to comply with reasonable work hours, having appropriate scheduling practices, including adequate rest between shifts, employing countermeasures that can be instituted in the work setting, like scheduled napping. Also to consider the design and technology, such as automation where possible, and having proper ergonomic design to reduce physical fatigue and injury. And finally, having an ongoing research program to monitor the fatigue risks and therefore allow organisations to respond at an early stage. Okay, finally, so what does all this mean? There were several consistent factors to consider when developing a strategy to manage fatigue in the healthcare sector. So it's very likely that a multimodal approach might be the best defence, particularly one with a very strong emphasis on organisational preventive strategies, such as ensuring work schedules and workloads are reasonable, and providing opportunities for adequate rest between shifts and having facilities for staff to take a proper rest break. Also, educating all the staff, including managers and leaders, about the impacts of fatigue on workers and patients, and promoting a cultural shift that does not normalise long working hours and having excessive workloads, and giving access to in-work time to programs that enhance workers' coping skills like meditation and mindfulness and resilience training, etc. And finally, working with staff who deal with patients to co-design workplace strategies to mitigate fatigue.